That's a good countdown. That was really good. So, talus. Anterior talus. Remember we did the little linking together? Okay. Anterior talus with the Walton wrap, dorsiflex, evert, rotate to central, this way. Posteromedial calcaneus, P to A, medial to lateral. Posterolateral calcaneus, P to A, draw down the joint here, come across to the sustentaculum tali on the other side. So, anterior navicular, posteromedial calcaneus, posterolateral calcaneus. Now you can do a braid contact across for the navicular. For the cuneiforms, you can skew medial or lateral for medial or lateral cuneiform. So, make the braid at the ankle, talar neck, dorsiflex, so you're on the navicular, dorsiflex, set through. Tissue pull from the navicular to the cuneiform, dorsiflex, pull through, or you can do medial or lateral. Cuboid, superior cuboid, hook your fleshy pisiform on the cuboid, pull down as you stabilize the calcaneus. Go to this side. Anterior navicular. If you have a posterior talus, palpated by feeling the talar dome here. As you dorsiflex, you feel the dome prominent posteriorly. As you plantar flex, it's supposed to come forward or glide forward. If it doesn't, bend the knees to 90 degrees, bend the knee to 90 degrees. Fleshy pisiform on the distal tibia. Stabilize and set for a posterior talus. So I'm going to do this on both sides. Metatarsal base, Lisfranc articulation, 1, 2, and 3. Knee, foot flat, hip, knee, and foot in a straight line. Stand perpendicular to the adjustment. Roll the knee in, little toe comes out. Roll the thumb into the yielding space between the first and second metatarsal, sliding to its most sensitive zenith. One content on the metatarsal base. The way I do it is another one on the cuneiform. Set through at the same time. You can also roll into the second and roll into the third to mobilize this middle part of the foot to open up the lengthening of shock absorption. Bend the knee to 90 degrees. Now, sometimes I assist by pushing the proximal in this way as I go P to A. This way. Yes? Oh, I forgot this from the other side. On your back. Posteromedial calcaneus. Anterior fixation of the distal tibia for a high ankle sprain. I'll show it on that side too. Stabilize this side of the tibia this way. Fleshy pisiform right into the distal tibia on the syndesmosis joint, not on the lateral malleolus, on the syndesmosis joint. Squeeze in, roll it into your palm, and set down with your fleshy pisiform there. Okay, switch. Come in here, move proximal to the fibula, lateral malleolus, and set through with the distal end. Okay, back on your side, facing this way. Bikini pose. Okay, your proximal fibula, hook the ankle on your inside shoulder, keep your head outside, don't put your face between your patient's legs. That's a no-no. Hook the fleshy part of the lateral gastroc into the neck of the fibula and setting across the joint line this way. Don't pull the muscle out of the way and get on the bone. It really hurts. Use the muscle to work with your adjustment. Move up a little bit. That's good, right to there. Now I'm still working on the high ankle sprain, going P to A. So I go A to P, inferior to superior, P to A through here, just to break up the syndesmosis joint in many different directions. Okay. Back.
Inferior navicular.
Stand on the side of the table right here, facing away from me. That's right. So this is how you can do how you can adjust a dropped cuboid, a dropped navicular, a dropped cuneiform group, a dropped metatarsal base. Okay? So you Keep the foot in this position. Move the knee as far as you can that way. Good. Look straight ahead, please. There you go. So you find the crease on the find the, if I'm going on the other side, I'm feeling for the navicular and coming this way. Okay. So I'm going from the navicular, finding joint space, taking the contact, and setting through P to A. Find the navicular. Here's the navicular talus joint. Here's the navicular cuneiform junction. So if I'm moving the cuneiforms, I move my contact from there to there. Just one finger breadth coming through. Now I take this contact and turn it this way to get the cuboid. So if it says right foot, I use my left hand to set through. If it's right foot for navicular, cuneiforms, metatarsal base, it's right hand, right foot coming through this way. Okay, so and if you have a drop piece, you use a drop piece with that also. Okay, stop for a second. And then 2 fingers.
Patella
Also,
alta.
please come dressed to expose yourselves. 1 or 2 eyebrows. Okay, so 2 fingers, make a bracket, lift the patella up, so you're coming through underneath. Coming low, coming this way. Am I actually releasing the patella or the fat pad and dread caps? Yeah, so you don't want to scour the kneecap into the femur, that would be bad. Okay, no scouring. So this is for patella alta. Limbo, how low can you? Oh, same thing. You need to be low for doing these adjustments so you don't scour the kneecap onto the femur. Okay?
So we have to come from both sides for patella alta?
How do you adjust a patella alta? Or how do you adjust a patella baja? One or the other, not both. Yes?
Yeah.
Lift the knee, knee down. So I can block the femur.
What's the listing?
This is anterior medial tibial plateau. So that is here. But it's also the same position for a posterior, or if you have a posterior lateral tibia, so the whole tibia is laterally rotated. So if it's just anterior on the medial side, stabilize and set. If it's a laterally rotated tibia with both an anterior and posterior lateral, you come femur tibia and set on the blocks. Yes? Find the end of the femur, go distal 4 inches. Put the heel of your hand here, push up toward the axilla, rotate into a horse stance, lift up into the hip, and once you get there, chicken dance and throw the baseball, let it drop. So I'm not thrusting into the, for this one, not thrusting. You come in and then let it drop. Switch.
It's okay.
Arm bar. Heel of the hand. Press. Rotate heels into horse stance. Lift up and let go. Let go. Okay. Figure 8. Do a figure 8 and move the hip around. Or if you have a superior, what's the listing? Superior
coxofemoral.
If I have a superior coxofemoral joint, grab the distal femur, squat down, and traction and pull. Sometimes they say on boards, a hold onto the ankles.
Yeah, on boards, follow the directions.
Exactly. If they say a bimanual contact with the distal tibia fibula, to relieve this subluxation, what do you grab? You grab this. They say, how would you do this? Safety for myself or my patient, I'd probably do this to reduce the superior coxofemoral. Da, da, da. So then the next one, if that doesn't make it, do light scouring of the joint. Bring the knee in, feel where it has a light restriction. Come in, medium depth, scour, scour, nothing really, really hard. It's medium depth thrust. Then you bring it back up, and then you see that it doesn't have the adhesion. You do it for external rotation also. Look for the restriction and come through. You're just trying to loosen up the joint capsule. Good? Okay, so joint play, rib cage, joint play. If the ribs are not going superior regionally, it could be restricting exhale. So far, so good. Spinous, transverse. Take the contralateral transverse over. Get your hand into the groove. Take a breath in and out. Wiggle, blow. Wiggle, wiggle, hold, set. And then you work through all the rib cage, whatever stuck going this way, you release going this way. And what's the goal? To release these ribs off of the thoracic spine so it can find its own place. Now what if it's my breathing instruction to my patient.
Inhale,
Breath
hold.
in and hold your breath. And hold your breath, but relax. Wiggle, wiggle, wiggle. Hold on the contralateral side, set on the ipsilateral. Hold contralateral, set. So my holding on the contralateral side rolls his rib cage up to unweight this side coming down. Now, is this over adjusting? No, I'm just relieving the extremities off of the spine. Okay, on your back. Test for only women or men or both? Both. Men and women always put their hands here. I'm stabilizing the sternum with my fingertips. Second rib here, fleshy pisiform tissue pulls from the sternum to the cartilage. You do not have a contact on the cartilage bone junction at the sternum. You want it past, so you loosen it. Breath in, hold your breath, roll out, breath in, hold breath, no blow out, roll out the slack, lean over, set, blow out, follow it down, roll out the slack, bend over, set. So you're just stretching to loosen the articulation. You're loosening the joint capsule. So you can do that all the way down to the bottom of the sternum. Yes, yes? Okay, I'm going to move my hips this way. Here, find the cartilage, find the bone, tissue pull to the bone of the rib, breath in, hold breath, lift, set, blow out. Now, my elbow can come up a little bit because the ribs are falling away. And the 6, but 5 is right here. So I ask the patient, female patient, I have one more, can I adjust this rib? She says yes. First thing I say is take a breath. Take a breath, move as much of the breast out of the way, set, come back, blow out, come back in, set, and you're done. On the left, I stand forward on my right leg, contact the body of the sternum, stabilize the manubrium, breath in, hold breath, stabilize the manubrium, set the body. Blow out. If it didn't move, do it again with the breath out. Okay? Now, if I want to do the manubrium on the left side, I leave my hands in the same position and I pivot my body. Breath in, hold breath, stabilize the body, set the manubrium, blow out, stabilize the body, set the manubrium. Okay, side of the body, breath in, hold, stabilize, set, blow out, stabilize, set. If it's the manubrium, I just move my body 90 degrees, not my hands. Stabilize, set, with the breath in and out. Patient's opposite hand, left hand. Good. Holding the breast down for females. Take contact on the sternum, hand on the first or second rib. But my angle is going to be this direction. Breath out. 1, 2, 3, 4, 5, 6, 7. So see how I'm going down to try to get the ribs to exhale better. This is good for asthma, good for bronchitis, good for all those things. Okay? You just have a couple more. Sternoclavicular joint. Okay, I'm going to stand right there.
Okay.
Okay. Unless you want a picture of my ass. No, you don't. I'm not saying nothing. Okay. Well, so, for a medial superior clavicle at the SC joint, I'm going to take the clavicle with a very shallow thrust, more medial lateral. What landmark am I adjusting just under? Coracoid process of the scapula, yes. So I'm going this way. Now, if it's a medial and inferior, see how I'm switching my body alignment and aiming toward what other landmark?
Upper trap or middle
Middle
trap?
of the upper trap. So I'm coming into here, don't choke your patient. Coming in and set through. Yes? Or if the scapula is lateral, I can lift the scapula up and in and set. Yes? Lie on side facing away from me. Scapula scour, tuck elbow. Scapula scour. Elevate, rotate behind the head and thrust to bring the scapula up, adduct, and behind the head. Yes? Up and set to release the scapula-thoracic junction or rib cage. Take the heel of the hand under the clavicle, go up and straight back to release the clavicle off the apex. Take the heel of the hand on the lateral border of the scapula, bring it inferior, down, in, and scour the scapula off the rib cage. Keep the person perpendicular to the table. I have to keep them perpendicular so I can move the scapula on the back. If I let their shoulder come back, I can't get their scapula to come off. Okay. Sitting up. Face that way. This way. Clavicle is superior to AC joint. Sometimes the coracobrachialis will be weak if there's a problem with the AC joint. Okay. Stabilize the scapula, not the humerus, come into the clavicle and set. Set through to try to mobilize the clavicle off the AC joint. Because what's the purpose of this joint here? Generate afferents. Does it generate afferents if it doesn't move? Find out which way it's not moving and mobilize through whichever way you can get it to move. Okay, scapula, AC, SC for the class. Okay, okay, and now face them. Sorry.
You do it
Come to the hair more.
If you do it incorrectly.
If you do this incorrectly, this is an automatic fail if you're called upon to do this. Then an AI shoulder, your sternum has to be on that junction between the spine of the scapula and the acromion process. When you're doing the adjustment, it's coming in and supported in AI or anterior. It's right into your chest, right? Mm-hmm. Do not come underneath and rip the person up. Some people teach it a mobilization to jump and lift the whole arm up. We had a faculty member here that he was at a seminar and a guy did that to him. He had a curved acromion, gave him a compression fracture in the top of the humerus, tore his labrum, so he had a slap lesion, had paresthesias in his arm for months because it stretched his brachial plexus. Okay, so it tore his shoulder up, tore up his brachial plexus, and did a compression fracture in his joint from somebody jumping underneath and lifting him up and mobilizing the shoulder, all in one motion. Make it into little bites. That can really permanently injure somebody for the rest of their life. So if you're asked to do an AI shoulder, get on top of it so it's right into your sternum. Don't be underneath. See you next week.